or no, undergrad in med school. Can you hear me? No. I did undergrad and med school at Creighton University in Omaha. And then I had a very charismatic OBGYN professor who I kind of didn't really know what I wanted to do with my career. I went into med school knowing I wanted to be a doctor, but I didn't really know what kind of doctor. And I had a charismatic OBGYN professor that kind of talked me into doing OBGYN. Um, and then I was about halfway through my second year of OBGYN residency and really just was not happy. I wanted to do surgery. I knew that I didn't really want to be up all night delivering babies. And so tried to switch, actually. I was going to switch into general surgery at one point, but they wouldn't count my first year of OBGYN residency towards first year of general surgery residency. And so I stuck it out, but I knew that I didn't want to be a generalist. I wanted to be doing surgery, mostly surgery. And so I looked at the GYN oncology fellowships, but that was another 4 years. And my wife was in residency in Chicago. I was in Virginia, so we were split up, and the prospect of potentially doing another 4 year fellowship was daunting, to say the least, and potentially being apart again. And so I kind of started exploring these minimally invasive GYN fellowships, and I really didn't know a whole lot about them. My experience with endometriosis in residency was limited to one lecture, maybe in 4 years. There must have been more, surely, but I don't remember them at all. I remember one lecture, and I don't remember scrubbing into a single endometriosis surgery in my entire 4 years of residency. Honestly, I don't. I do not remember doing a single endo surgery. And so, kind of coming out of residency, I saw these minimally invasive fellowships, and I had really had no idea what they were about. And I ended up going down to Chattanooga, Tennessee to interview. And as part of the interview, they brought us into the OR and they basically interviewed us while they were operating. They were interviewing us. And I just remember like they were doing this um really complex stage 4 endometriosis case with bowel and bladder resection. And the attending, Dr. Scott Furr, was working with a guy named C.Y. Liu, and they were doing it themselves. They were doing their own bowel and bladder resections. And I just came back from that interview blown away at what these guys were doing down in Chattanooga. And I knew that that's where I wanted to be. I knew I wanted to be in Chattanooga with CY and Scott Furr, who are still, CY is kind of the OG endometriosis excision surgeon. And I just totally fell in love with those types of surgeries. They're very, very, very complex surgeries, very technical surgeries. You're doing things that are so far beyond anything that I had trained in my 4 years of residency. And I came out of residency with really not a lot of GYN experience. I had over 600 C-sections in residency, and I think I graduated my residency with 60 hysterectomies. And I was very aggressive about scrubbing into those cases. That was in the time of duty hour restrictions that were new, and if you were over your hours, you sort of had to go home. But there was always an expectation that you would be on L&D and delivering babies. And so the GYN experience, at least for in my residency, kind of got pushed a little bit to the wayside. So I was coming in after hours and not logging my hours just so I could scrub all these cases. And I still only graduated residency with 60. There were people in my residency class who, at the end of their 4 years, had done maybe 15 hysterectomies, 15 total. The requirement at the time to graduate fellowship or to graduate residency, a 4 year residency program, was you only had to have 10 hysterectomies, which, if you think about it, is kind of wild. So we've, and you didn't really have to have a single endometriosis surgery. So we've turned loose this entire generation of OBGYNs that are really good at delivering babies, but the GYN experience is not there. It's really lacking. And to put it into perspective, my first year of fellowship, I did over 500 hysterectomies in 1 year. And hysterectomy, I'm just using as an example of just, you know, and I did over 500 hysterectomies in 1 year of fellowship, whereas I'd done 60 in 4 years of residency, and that was because I was coming in on my own time just to get that GYN experience. So that's a little bit kind of that was a long-winded answer to,
That's
where I
okay.
trained and what I do. But for me, it just became a real passion. I love these types of surgeries. I think I think they're more, like I said, they're more complex at times than the oncology surgeries. When you get into a stage 4 endo case, there's almost always going to be bowel and bladder and periureteric involvement, and it's just they're so challenging and so rewarding at the same time. I think one of the things that I didn't enjoy about GYN oncology is that, unfortunately, I don't know how much y'all know about that world, but most of those patients don't fare all that well, even with, a debulking surgery where you optimally debulk an ovarian cancer or a cervical cancer. Most of them end up still not doing all that well. And the rewarding thing about the endometriosis world is you can do this really, really complex surgery and the patient can still go home the same day and they're going to do great. It's not this, you do a surgery and then they're in the ICU for a week and then inevitably the cancer recurs and they don't always do all that well. So the endometriosis world is just it's so challenging, but it's also so rewarding at the same time because those patients do really well. And these surgeries they're life changing. I mean, they really are life changing for patients who've experienced pain their whole life, experienced infertility, unexplained infertility. I'm sure Tara will talk about that, or maybe already has, but it's just such an amazing world to be a part of, and it's a small world. All of us excision surgeons kind of know all the other excision surgeons, and there's getting to be more and more of them, which is good, but it's still a relatively small world, and we all are close compatriots in this world. We all know each other, so it's just it's a cool it's a cool specialty, I guess, is what I'm trying to say.
Perfect. Do you happen to know how many surgeries you've done to date? And can you share a little bit about the Magic Nancy's Nook label that you get and how people get that?
Yeah, Nancy is I met Nancy for the first time probably 6, 7 years ago. I was at the AAGL, which is the American Association of Gynecological Laparoscopists, and that was an organization really started by these forefathers of minimally invasive surgery, your C.Y. Lews, your Harry Riches, your David Redwines. These are the guys that kind of started that organization, and they're the ones who run the fellowships. But Nancy was there. Nancy was David Redwine's OR nurse. And I don't know if you all know who David Redwine is, but he was really the first person to be saying we need to be cutting this disease out, not treating it with hormones, not burning it. So he was really the first one to really push excision surgery as what should be the gold standard for the treatment of endometriosis. And he was laughed at, he was castigated, and the same thing happened to CY Liu. They tried to take his license away. The local OBGYNs got together in the late 90s, early 2000s. So not that long ago, a little over 20 years ago, and tried to get his license revoked for doing laparoscopic surgery because that was not the standard of care. So I met Nancy at the AAGL, and Nancy was David Redwine's circulator nurse, and they really started the first endo excision program in America. And they had patients coming from all over the country. And as a result of their advocacy work, Nancy started this Facebook group. They used to be, this was in the old days, they were on AOL Instant Messenger. I don't know if you remember those, but they had little like chat rooms devoted to endometriosis. And it was Nancy and a group of advocates that kind of started this. And they basically vet surgeons as to who they consider to be a really good excision surgeon. And I bumped into Nancy. Yeah, gosh, it's going on 7 years now, probably. And I was just starting out. Um, Actually, it's probably about 8, 9 years ago at this point now, because I've opened my office. Yeah, it'll be it'll be 9 years this June, and I met her pretty much right away. But I just started my office up here in Idaho, and I moved up here, and everyone thought I was crazy trying to start an excision program, endometriosis specific clinic in North Idaho. And I was struggling. I mean, I was seeing two, three, four patients a week. Um, and then I met Nancy, and it just changed my life. She had heard about me, had heard what I was doing. She knew who trained me. And so she added me to this Nancy's Nook. If you haven't heard of Nancy's Nook, you really need to. And overnight, my practice probably was tenfold higher. I was getting patients coming in from all over Washington, Montana, Utah, and it totally transformed my practice, and got me. I started my practice 9 years ago this summer with it was me and an MA who was also my receptionist slash surgery scheduler slash uh, insurance authorization. It was me and one person. And now, fast forward 9 years, I've done between fellowship and my practice, I've now done over 4,000 excision surgeries, and I've done over 4,000 hysterectomies. And that's part of that is, we combine those sometimes. But yeah, I've done over 4,000 excision surgeries at this point. We've grown the office to, we have 6 core staff members, 2 excision surgeons, my partner, Dr. Young, and I, an MP, a PA, a lot of really good MAs. I mean, it was, like I said, 9 years ago, it was me and one employee, and now we're a team of 14 people. And yeah, between my partner and I don't know how many she's done at this point, but I know I personally have done over 4,000 excision surgeries. So it's a
All
lot.
right, that's a lot. The big
Yeah.
question, dive into the big question. Explain
Okay.
excision versus ablation.
Okay. Yeah. So there's a huge difference. The traditional method for treating endometriosis in the general world is A, ignore the disease, B, convince the patient that it's not endometriosis, that it's something else, C, put the patient on hormones, D, when the hormones don't work, put them on different hormones, and then E, reluctantly take them to the OR after they beg and plead, and you've grown weary of trying to convince them that they don't have endometriosis. You take them to the OR and you burn the disease. That's called fulguration surgery. But if the disease is near bowel or near bladder or near ureter, you don't touch it. You just leave it there. So you go in and just burn the spots that are easy to get to, and you leave the rest. That has virtually 100% recurrence rate, because you're A, leaving disease there, but B, not actually removing it. And so excision surgery is a laparoscopic approach, or minimally invasive. It can be laparoscopic or robotic, but you go in and you actually cut the disease out. You remove it no matter where it is. And that is the gold standard for the treatment of the surgical management of endometriosis. It has a much lower recurrence rate, but it is risky. You have to really know what you're doing, because if you're cutting into bowel or cutting into bladder and you don't really know what you're doing, you're going to hurt patients. And so if you have the training to do it, it's a really amazing modality. with a much lower recurrence rate. We typically quote recurrence rates of around 15 to 20% lifetime versus 100% recurrence at 3 to 6 months. So excision surgery, if it's going to recur, generally the disease, and it only comes back about 15 to 20% of the time, but it's down the road. It's usually, I think on average 5 to 8 years. People may have different experience. Other excision surgeries may have other excision surgeons may have different numbers or different experiences, but in my experience, it's been about a 15 to 20% recurrence rate at 5 to 8 years. So it really is, it's not perfect, but it is a much better tool than the fulguration surgeries where you're just burning it. And I think the other difference is that most of the fulguration surgeries are being performed by people that aren't always able to recognize the disease. So they go in, and that's the worst case scenario, is when they go in and then they tell the patient that they don't have endometriosis, despite the patient having all the signs and symptoms of endometriosis. They're told they don't have it, and that's really the worst case scenario, because then the patient spends another 5, 6, 7 years wondering what the heck is wrong with them before they finally get to a specialist. So that's the difference between excision surgery, actually removing, cutting out the disease, versus fulgurating or just burning it. And endometriosis is very rarely just purely superficial disease. It is in very early disease, but the longer it sits there, the more it's going to burrow down in. And so if you're just going in and burning the surface, you're not getting that whole lesion out. It's like an iceberg, and you're just sort of blowtorching the top of the iceberg. You're not going to get very far with that. So,
Is there an actual difference in the equipment that can be used too, that some might have access to versus what you have access to?
no, I mean it's the same. It's the same equipment, really. It's when typically when folks are fulgurating disease, they'll use a bipolar Cleppinger, it's called. It's like two little paddles that you squeeze tissue with, and it sends an electrical current between the two paddles, and that's generally they're just sort of grabbing lesions and burning them. Um, I don't really use a Cleppinger. My partner uses them a lot, but excision surgery, we're using I use in particular a device called the Thunderbeat, where it has monopolar, or excuse me, it has electrical current to basically cut the tissue, and then a bipolar component that uh, coagulates and seals at the same time. So you're cutting and sealing at the same exact time. So you're actually able to remove those lesions in their entirety with very little bleeding. And bleeding is bad because it causes adhesions. So you really don't want to have much bleeding during surgery, because that'll lead to adhesions. So that's it. It's not an equipment thing. It's a training thing, though.
Dr. Dewey, can you speak to, even though like the camera is laparoscopic versus robotic, like how you as a specialist using maybe better cameras are even able to see lesions, and maybe a generalist going in laparoscopically, like why are they saying, nope, I didn't see anything versus.
I I don't think I don't think that's an equipment thing. I think it's a training thing. I think if you're not looking at endometriosis all the time, it's sometimes hard to recognize. And there's this idea that all endometriosis is blue-black. That's the classic description of what you're taught in residency, what you're taught in your training, is that all endometriosis is blue-black. But we know that the vast majority of endometriosis is not blue-black. So if you're not doing endometriosis surgery all the time and you go in, a lot of endometriosis, especially in teenagers, is going to be clear or white, and it's very easy to miss. It's very, very, very subtle. And so I don't think it's a visualization issue from an equipment standpoint. I think you just don't know what you're looking at if you haven't done thousands and thousands of cases. So I'm straight laparoscopic. I did over 500 robot cases in my fellowship training, but we just we actually don't even have a robot at my hospital. So it's not a laparoscopic versus robot or anything. It truly comes down to how well you as a surgeon can recognize disease. And we see patients all the time who've been scoped and told that they do not have endometriosis. And we go in there and it's subtle, but we always find it in these patients who have those symptoms. So it really does come down to a training thing. Sometimes the lesions are so obvious, and I'm questioning how someone could possibly they are blue-black lesions. I don't know how they get missed. They're always very obvious to me, but a lot of times those more subtle lesions, it can be red, it can be yellow. The clear and white endo gets missed a lot. And that's how it typically looks in younger patients, teenagers. So it's very easy to miss in teenagers if you don't know what you're looking at.
Can you share more about the most common symptoms and some unique symptoms that one may not even think is endo?
Yeah, I think traditionally we're taught that endometriosis is all about pain. I'm gonna put my blinds up a little bit and get some sun in here. We're taught that endo is all pain and it's all period pain, right? That's the classic description of endometriosis. But when you start doing a deep dive into symptoms, I think pain actually oftentimes becomes less indicative of pure endometriosis to me. For me, the classic symptom, especially I think the first sign symptom of endometriosis is cyclical gastrointestinal distress. These 14, 15, 16-year olds with bloating, nausea, constipation, diarrhea, vomiting on their period. If there's especially a cyclical nature to those gastrointestinal symptoms, that to me is endometriosis until proven otherwise. And then as the disease evolves, there start being, the pain is generally part of it, but those gastrointestinal symptoms will evolve. They'll stay there. Most patients, 96% of patients with endometriosis have gastrointestinal distress, and it doesn't matter what age they are, but especially as a teenager, I think those are the most prominent symptoms. Painful urination, painful intercourse, which is typically a sign of pelvic floor dysfunction. Um, Infertility, I think that's often an overlooked symptom, even though 50% of patients with endometriosis will have infertility. For some patients, that is their only sign and symptom is infertility. And they get these infertility workups. They didn't really understand that their GI pain or their painful periods were not normal. They didn't realize that. And so as part of the infertility workup, it'll be discovered that they have endometriosis. I've seen patients who have stage 4 terrible disease and with bilateral endometriomas and they really don't have a lot of pain. It only got discovered as part of a fertility workup. So yeah, gastrointestinal distress, pain, painful bowel movements, painful intercourse, pain with urination or urinary frequency, urgency, infertility. I think those are kind of the main signs and symptoms. But endometriosis is a funny disease because it's very, very highly inflammatory tissue. That's what endometriosis is when you boil it down. It's just very highly inflammatory tissue. And so I think there can be this sort of downstream cascade effect on the body. And I never tell patients that their symptoms aren't part of endometriosis because we don't know. And when you have very highly inflammatory tissue in the body, it can create a whole myriad of symptoms that might not be traditionally recognized as endometriosis symptoms. So,
I'm jumping around here a little bit, but is there any testing that can be done beforehand that would say you have endo, you don't have endo, imaging, anything like that? Or how often do you see that come? What's necessary, what's unnecessary when it comes to imaging?
I do think that imaging is important. Peritoneal disease is generally not going to show up on imaging. There are some proponents of ultrasound, and they're saying that they can see these peritoneal lesions on ultrasound. And I think, there are very good ultrasonographers out there, but most disease, if it's not involving the ovaries, is going to get missed on kind of standard ultrasound. To me, a patient will tell me they have endometriosis, and to me, a negative scan is actually more indicative. If a patient's coming in and saying they're having cyclical gastrointestinal symptoms, chronic pain, and they get told, well, your scan was normal, so your ultrasound was normal, so it's not our issue, it's GI, or go see whoever. But to me, if a patient comes in with pain and symptoms classic of endometriosis and they have a negative ultrasound, that to me is actually more indicative that they have disease, because I don't think they're making it up. I don't think they're just seeking attention or whatever. So to me, a negative scan in the presence of symptoms is actually even more indicative of endometriosis. Um, if the patient has endometriomas, those are pretty much always going to show up on ultrasound. So that's where ultrasound is very sensitive for the presence of endometriomas. And then typically what we'll do is, if a patient has an endometrioma or bilateral endometriomas, a lot of times we will get a pelvic MRI, because that can help. There's almost so, and I don't know if you guys, how much you know about sort of the staging system and everything. The staging system was kind of this arbitrary, not arbitrary, but it was a modality in which researchers could communicate with each other by stratifying severity of disease. And so stage 4 is the worst. And stage 4 endometriosis typically means that there's endometriomas, which are cysts of endometriosis on the ovaries. And whenever there's endometriomas, that's a sign of much more advanced disease. And so when there's bilateral endometriomas, or even a solitary endometrioma, there's virtually 100% of the time there's going to be disease down that pelvic sidewall as well. There's typically going to be rectovaginal involvement, so that posterior cul-de-sac where, this is the back of the vagina, this is the front of the rectum, the posterior cul-de-sac. You can get pretty advanced disease in there. We almost always see rectovaginal involvement when there's bilateral endometrioma. So that's an area where MRI can be really helpful and really beneficial. So we typically do order pelvic MRIs on patients with sonographic or ultrasound findings of endometriomas. From a lab work perspective, there's not really anything. There's a test called the Receptiva test, which is they do an endometrial biopsy actually, and they send it to a lab, and it has a really high sensitivity for predicting endometriosis in the body. I think it's 97% sensitive, but it is never covered by insurance. They don't even try, the company doesn't even try to bill insurance that I'm aware of. So that test is very, very expensive, and it's painful. I don't know how many of you out there have ever had an endometrial biopsy. I certainly haven't, but they're not fun, and especially in a patient who's maybe 15 or 16. I'm not going to traumatize a 16-year-old with an endometrial biopsy just to prove that she has endometriosis. Her symptoms have already told me that she has the disease. So I've actually never done the Receptiva test, but that's really the only non-imaging modality that is available. Various people have tried various blood tests and things like that, and nothing's ever really panned out. So yeah, that's kind of the long answer.
Can you share more about why you feel pelvic floor physical therapy is important for someone with endometriosis?
Yeah, pelvic floor physical therapy is, to me, the most important part of endometriosis care. My job becomes relatively easy in the grand scheme of things. It's hard at the time to do these surgeries a lot of the time, but it is a few hours of my time versus the pelvic floor physical therapists who are spending weeks or once a week with these patients for months, years sometimes. So pelvic floor physical therapy becomes the most important aspect of a treatment plan. And that's why it's so good to have a good relationship with the pelvic floor physical therapists because they're doing the work. And I don't know of the 4,000 whatever excision surgeries that I've been, I don't know that I've ever met a single patient who didn't have some element of pelvic floor dysfunction as a result of their disease.
So Dr. Duke, that's a beautiful segue into, a lot of people say, what's with this Dr. Duke in Idaho? Why do you all talk about him? I don't know if you can see beautiful Natalie in the back of the picture there, but, Natalie.
Hi, Natalie.
And, for
Long
me.
time no see. How are you?
Yeah. So as I was saying, we've had Jones PT's been open for 18 years and I was in the thralls of building a business, having children, doing the best I could. Natalie comes on in 2020 and she's like, aren't you sending him for excision surgery? And I said, what? And so can you kind of explain how you met Natalie, your relationship? We are so grateful for her presence in North Dakota and literally bringing the gift of knowledge and you essentially to North Dakota. Can you speak to that?
How I met Natalie? So Natalie was here in Coeur d'Alene working with Sherry DiBiase and at Lake City Physical Therapy. And when I first got to town, we had so when I was in Chattanooga, we had a wonderful relationship with our pelvic floor physical therapists there, and we were sending all of our patients and working collaboratively. And when I first moved to town, I joined a practice, and I remember asking the partners, "Hey, who are you guys sending your patients to for pelvic floor physical therapy?" And they looked at me like I had two heads. I was met with this, what are you talking about? Pelvic floor, like what? What is that? And so I literally, about a month into my first year of being here, just started. This was before I started my own practice. I was with a different group, and so I just started cold calling physical therapy offices in town and asking if they did pelvic floor physical therapy. And the vast majority of them had no idea what I was talking about. And I called Lake City Physical Therapy. It was probably the ninth or 10th physical therapy office in town that I had called. And the person that answered the phone said, "Hang on a second. I'm going to go get Sherry." And so Sherry and I had this probably 20-25 minute conversation about what I was doing and pelvic floor, the importance of and why I felt pelvic floor physical therapy was so important. And she was doing that at the time. And so we started this really amazing collaboration, Sherry and I did. And Natalie came on as sort of Sherry's protege, essentially, and learned from Sherry. And I think Sherry, right, Natalie probably taught you a lot. And then and then Natalie left, sadly, and we would like her back. So anytime, Natalie, anytime you want to come back, you're welcome. We would love to have you back.
We're gonna cut the video there.
Yeah.
Yeah.
And we want
Pardon?
to open up to you, anybody to ask questions at this time too, so you guys can get a chance if you'd like. Yes. Go for it.
How, can you see cases where the tissue goes around the heart?
Heart involvement of endometriosis. Have you seen that?
Yeah, we do see it on a fair number of occasions. I used to be a little bit more cavalier about resecting it myself, and I think there's a video of it on my Instagram actually of me like resecting endometriosis from around the pericardium there. I've become a little, I'm finding myself kind of doing less and less of that lately. Because I do think that it probably, well, it is best resected by a cardiothoracic surgeon with experience in endometriosis. And unfortunately, there are not very many of them out there. They're kind of at these bigger centers, like the CEC down in Atlanta. They do a lot of thoracic endometriosis. Nick Fogelson out in Portland does a lot of thoracic endometriosis, but they have a cardiothoracic surgeon generally who works with them to remove that disease, because sometimes you've got to like put mesh in the diaphragm if you take too much out. Um, and they're very, I mean, they're very, very complex surgeries. So I've found myself, I'll still do a lot of kind of the more superficial diaphragmatic disease, but I've become a little bit less cavalier about removing deep, deeper diaphragmatic disease. So, because it is, I've collapsed. You know, you go through that diaphragm, you're gonna collapse the thoracic cavity, and then you got to put chest tubes in to reinflate the lungs, and it's super painful for patients. So, if we're seeing kind of deep thoracic or deep diaphragmatic disease, that's usually a sign of thoracic endo. And so we'll often send those patients to a bigger center, just because unfortunately we don't have a cardiothoracic surgeon where I'm at. So
How do you find it in different parts of the body? You're just like zooming around the whole body and
Hear that?
and discovering.
How do you
it, or-
find it? You just zooming around in there? How do you see it all over? Blow us up with, what do you
yeah,
do?
we have a very systematic approach to endometriosis. It's the way that I've always done it, which is we actually start at the diaphragm, and we're looking at the diaphragm. We get our camera sort of up the sides and under the liver, to get around to the back of the liver to see, because when you're looking just at the diaphragm purely, you're generally only seeing a maybe half of the diaphragm. There's a whole sort of back posterior part to the diaphragm. So we always start and we're looking up there, and then we're looking at the entire small bowel, and often, I mean, we're picking it up and sort of running the small bowel looking for lesions, and then we go down into the pelvis and start looking for disease. So it is a very systematic approach to making sure that you're covering every square inch of the abdominal and pelvic cavity. So we do, I I think a lot of people, when they're doing, not maybe not excision surgery, but most of the generalists who are doing, if they're doing endosurgery, I'm fully convinced they don't ever even turn their camera around to look at the diaphragm. So you really do have to do a systematic approach, and we do it the same way every single time. Like all 4,000 cases, I always sort of follow my system and start and finish the same way every single time, just to make sure we don't miss disease.
One quick announcement, our lovely photographer has to leave pretty soon, so if you wanna do a headshot, just sneak away and do that. Okay, next question. I'm gonna move to virtual. There's,
Okay.
Okay, I gotta share.
okay, go for it.
How long does excision surgery take, and then what does recovery look like?
How long does it take and what does recovery look like?
Yeah, that's a question I get a lot. The surgery depends on what's there. If it's, and I tend to be a pretty fast surgeon. I have always just been fast. That doesn't mean I'm unsafe or reckless. I'm just fast. I've always been a very, very fast surgeon. So if you've got just minimal stage one superficial endometriosis, those cases sometimes can take 20, 25 minutes. And then if you've got stage four endo with rectovaginal involvement and bilateral endometriomas, sometimes those cases are 4 to 5 hours. So it all kind of depends. And we're pretty good about sort of legislating how much time we need in the OR. Like if I know that a case is going to be really involved, I might only book 2 cases that day instead of 4 or 5. So generally based on imaging, we have or if patients have had surgery before, we kind of know, you know, what we're getting into when we get in there. So the length of the surgery really varies, and I think the recovery, this is another question that I get all the time. That also really varies on the extent of disease, how long it's been there. But I generally tell patients it's going to be a minimum of 3 to 6 months before you heal up from these surgeries. I think sometimes there's an expectation of an immediate healing, waking up and feeling amazing the next day type of thing, but that's not reality. It does take a while to recover from these surgeries. And I think from a pelvic floor perspective, in conversations with my pelvic floor PTs, I mean it's sometimes years before the pelvic floor comes back online. So
And I'll just jump in and say that too, there's a lot of pain neuroscience with that. You've been dealing with a chronic disease for a long time, or been told you don't have a disease, not sure. There's so much with pain, brain, neuroscience in there that we also work on extensively when we're working on pelvic PT. It's not just the pelvic floor, it's physiologic quieting of the entire body and working on that pain, brain piece.
correct.
Can you see any of the chat questions?
There was one that popped up, but it disappeared. Oh, wait, maybe.
There we go. How about that?
Um,
Do you see back problems as a symptom? I have severe bilateral spinal stenosis in my lower back and sciatica problems.
well,
But
we can start at the beginning. The sliding sign, a good indicator for endo. Yeah, for sure. The slide, we call it the slide test. And what you're looking for as you're pushing that probe is to see, does the rectum sort of and the uterus kind of slide independently of one another? If they don't, that's a sign that generally there's pretty advanced rectovaginal disease, and you've got an obliterated posterior cul-de-sac. So yes, the first question from 850 Natalie was that Natalie Net was the slide to, yeah, that is a good one. And our radiologists and sort of radiology techs, because we're sending them so many ultrasounds, they're looking for that. They're doing that during we don't do our own ultrasounds, but we have a very good radiology person who he knows what we're looking for. His name is Brad Griffiths, and he reads most of our scans. The next question was, what are the benefits of prescribing progesterone after endo surgery? Do you feel progesterone can slow the return growth of endo? I do not prescribe any post-op suppression medications. I think there is that's sort of the recommendation for following surgery, not not in an excision world, but in the generalist world. They want to put all their patients on post-op suppression. There's actually no evidence that post-op hormonal suppression prevents recurrence of endometriosis. So if I do my job and actually remove all the disease, there's no reason to put patients on post-op hormonal suppression. I think post-op hormonal suppression is a crutch for not being able to remove all the disease. And there is no evidence that with optimal excision that post-op suppression prevents recurrence of endometriosis. So no, I don't put any patients on any hormonal. If they're wanting it purely for birth control because they don't want to get pregnant, sure. But I don't put patients routinely on post-op suppression. What if you choose to never get the surgery? Will it just continue to get worse? I don't know. Most cases, yeah, probably. But endometriosis is a disease that has a lot of genetic components to it, and some disease may not worsen over time, some may. Some responds beautifully to surgery, some does not. So choosing whether or not to get surgery, and excision surgeries they are a big deal. But David Redwine always taught me that there's two indications for surgery. There's pain and there's fertility. And if pain is relatively tolerable, and some patients do okay on hormone suppression, you know, and their symptoms are generally okay. And if fertility is not a concern, I don't think surgery is always indicated. I don't think every single patient needs surgery. So that would be the answer to that is we probably don't know. Some of it may get worse, some of it may not, some of it may just kind of stay the same. Do you see back problems as symptoms? I have severe bilateral spinal stenosis in my lower back and sciatic problems. I don't know that spinal stenosis in and of itself. I'm not aware of that, but we do see back pain a lot. I think that's a manifestation oftentimes of pelvic floor dysfunction. But we also see a lot of and as our sciatic problems, yes, you can have true sciatic endometriosis, and um, I've certainly dissected into more than one sciatic nerves approaching it laparoscopically. I've done it a fair number of times, so I can access the sciatic nerve from the pelvis. Um, we do see sciatic endometriosis on occasion, and we're able to resect it off the sciatic nerve. But I think most sciatic and lower back pain problems are probably more indicative of pelvic floor dysfunction, and adenomyosis will cause a lot of lower back pain. Do you guys know what adenomyosis is? Has that been discussed or?
You can go over it.
Take it away.
Okay, so endometriosis is tissue. I feel like I do this definition for every single patient, so I feel like I've done this thousands of times, but um, endometriosis is tissue similar to the lining of the uterus, right? So the uterus is a muscle. It's called myometrium. It's a smooth muscle. And lining that smooth muscle is the endometrium. And that's what you slough off every month when you have your period, and it regrows in anticipation of an embryo implanting. When the embryo doesn't implant or there's no embryo to implant, then you slough it off and that's your period. And so endometriosis is tissue similar to the endometrium. It is not actual endometrium, and that's a critical distinction because that's Sampson's theory from the 20s was that endometriosis was retrograde menstruation. It was menstruation that shot out the fallopian tubes. And so that was basically the basis that was the origin theory of endometriosis, and it's still probably the most widely accepted, but it's false. And that was the basis for hysterectomy cures endometriosis, suppressing menstruation cures endometriosis. We know that it doesn't, but that's still unfortunately the basis. That's why everybody with endometriosis gets hysterectomies in the generalist world. Um, Adenomyosis is a disease where the actual endometrium that you slough off is very glandular. We call it glandular tissue because it has a lot of little glands in it, and those glands secrete cytokines and prostaglandins, which are the chemical recruiters for inflammation, pain, fevers. So um, when the glandular endometrial tissue works its way out into the muscle layer of the uterus, that's adenomyosis. And that's where hysterectomy is indicated. And hysterectomy can be a very powerful tool in the pelvic pain world, but you have to know why you're doing it. If you're just routinely doing hysterectomies because you're trying to fix endo, that's fallacy. That's wrong. That you're not gonna fix endometriosis with a hysterectomy. You fix adenomyosis with a hysterectomy. So that's the difference. And adenomyosis, often patients will have very heavy, clotty periods. That is not a symptom of endometriosis. So endometriosis, because by definition is outside of the uterus, it does not cause heavy or clotty bleeding. So when patients have heavy clotty bleeding, severe pain during their cycles, lower back pain, the other classic symptom of adenomyosis is pain radiating down the fronts of the legs. So radiating down the front of your thighs, that's adenomyosis pain. Um, and so that's a critical distinction. I think for a lot of general OB folks, heavy bleeding, clotty bleeding is a sign of endometriosis, and it is not. It is absolutely not a sign and symptom of endometriosis, it's a sign and symptom of adenomyosis. So that's kind of the difference between the two. The other question was, do I need to do bowel prep for endo surgery? Well, if you have bowel involvement, yeah, we bowel prep our patients, or if MRI is showing invasive disease or rectal tethering or completely obliterated cul-de-sac, then we will bowel prep those patients. Uh, I remove the appendix routinely. That was the second part of the question. If endo on the appendix, will you remove the appendix or send it general surgery? I do. Me and my partner do all our own appendectomies. I think just about every excision surgeon does their own appendectomies. I recommend that the appendix comes out virtually 100% of the time, even if it doesn't look like there's endo on it, because there's very good data out there that endometriosis often involves the appendix, especially in stage 3 and 4 disease. There's like a 30% involvement rate with that the appendix has endo, and you can't always see it. A lot of that endometriosis is what we call intraluminal, so it's on the inside of the appendix. So you can't see it externally. And then there was a paper that Nina Agarwal did. She was CY Lou's, one of CY Lou's first fellows. And she showed that there was a significant reduction in pain with the appendix coming out, even if the appendix was quote unquote normal on pathology. So we remove the appendix virtually 100% of the time, and we don't send it to general surgery. So
Do you recommend hormonal treatment for adenomyosis if someone is trying to maintain fertility?
yeah, adenomyosis is a nightmare, right? Because the definitive treatment for it is hysterectomy. And in someone who's 19, 20, 21, or however old, and wanting to conceive, wanting to start a family, wanting to have more kids, adenomyosis is tough because there really isn't a great treatment for it. It's either eventually the uterus comes out, or you suppress menstruation, suppress. So those are cases where we will do hormones suppression. I think IUDs are great for adenomyosis because they really significantly reduce the bleeding and the clotting that we associate with adenomyosis. So I do like hormonal IUDs. Copper IUDs are an absolute disaster in patients with adenomyosis. I think a lot of patients want to be natural or more natural, and they don't want hormones, but a, a copper IUD works by increasing inflammation. So they've done studies that show that when patients or when you put a copper IUD in, it increases inflammation, it increases macrophage count in the fluid of the inside the uterus, natural killers. So it basically works by inducing an inflammatory response. And that inflammatory response is prohibitive to an embryo implanting, because the embryo kind of, maybe comes down and the tube and sees that inflammation. Is like, nope, I'm out of here. Like, and it's so copper IUDs, if you think about adenomyosis, adenomyosis also creates a state of inflammation within the uterus. That uterus becomes very inflamed. It looks different on laparoscopy. So if you put a copper IUD in a patient with adenomyosis, it's awful. Patients will really, really struggle. And their periods oftentimes will get significantly worse, more painful, heavier, clottier with a copper IUD. So.
If you see people that have both and.
Endo and adeno.
Oh,
That,
I think most people do.
okay.
Yeah, I think there's a the data would sort of say, I mean, I've seen it kind of all over the place. I've seen if you have deep infiltrating endometriosis, there's like a 50% adenomyosis rate. I think most patients have both. I really do. I think that there's something about the way that is all laid down embryologically. I think most patients have both.
Does he require imaging, or does he do imaging on every patient he sees? And then also, how long do you have to wait to try to conceive after surgery?
Um, yeah, I generally would like at least an up-to-date ultrasound, and up-to-date is, within 3 to 6 months. I generally would like to see an ultrasound within 3 to 6 months on virtually every single patient, so that we can legislate for the presence of bilateral endometriomas. which we know will make it a longer case. As far as conceiving post-operatively, I don't put any time limit on a patient at all. I have at it. So it's, yeah.
What about Lupron and Orlissa?
Orlissa and Lupron. Yeah.
I've never used either. I've never prescribed either one in my career. I've never used either one. For me, it it's this idea of it's just another way of kicking the can down the road. And that's essentially what all hormones are doing. And I think I mean, that's a whole different conversation, but any type of hormonal intervention, I think there's a misunderstanding amongst even the general OB providers that when you put patients on any kind of hormonal suppression, that you're actually treating the disease, and you're not. You're treating symptoms of the disease. So the disease is still there. It's long been known that endometriosis aromatizes its own estrogen supply, and by aromatize it means it actually creates its own estrogen supply. So you'll see endometriosis in postmenopausal patients all the time. You'll see it in patients who've had their ovaries out or been, we call it, well, castrate. I mean, if you castrate a patient by removing their ovaries, they will still have endometriosis. I took pathologically active endometriosis out of a 72-year-old before. So we do still see it a lot in older patients, but um, the the answer to the Lupron or Alyssa, I mean, it's really just another form of trying to suppress symptoms, and they're fairly powerful. Do you guys know how those medications work? I mean, they basically induce menopause, and the idea is that if you somehow starve endometriosis of estrogen, that it'll go away. But endometriosis again produces its own estrogen supply, so the disease is still there. And you can't keep a patient on Lupron or Alyssa indefinitely because of risks of, bone loss and things like that. So it's if you imagine a hypoestrogenic state for very long, it's going to have significant effects on a patient's body. And so you really can't keep a patient on those medications. So again, it's just another way of kicking the can down the road because as soon as they come off it, all of their symptoms are going to come back. And for a lot of patients, it doesn't work. And the medications, in all honesty, have not been shown to be superior to regular old birth control. I think if you're going to have to put a patient on something, I mean, norethindrone or progesterone or progestin is fine. If you want to, if a patient, if surgery, if they're not, time's not right, or they're not ready, they've got a wedding in 6 months and surgery's out. I don't see a problem with that, but I've never used those GnRH agonists, antagonists. I just haven't used them.
And I will say, hearing the story that we hear with patients, it is not uncommon for us to hear a patient told, or they have been on Lupron or Depo, and they were told, or Alyssa, told by their doctor, they have to go on this to prove they have endo, whether they get better or not. These medications often cause a lot of very fast weight gain. They cause a lot of hormonal swings. We've had patients who unfortunately become suicidal on them, so they are not a drug to be lightly taken. And then they're very angry because they find out, wait, this didn't fix my disease. No, it actually didn't change the disease at all.
Question?
So you just mentioned, removing endo on a 72-year-old. So what would be the indications for someone that's postmenopausal? Or
Postmenopausal indications of endometriosis.
Postmenopausal indications for
What do you
surgery?
commonly see? What do you commonly see as symptoms of
Oh,
a menopausal patient?
the same symptoms. This patient was still having a lot of pelvic pain and a lot of gastrointestinal distress. So, and she had a history of endometriosis. Like she had known endometriosis in her earlier years, but every doc she went to told her at 72 it was absolutely impossible to have endometriosis anymore because she was postmenopausal, but she did. I've taken active adenomyosis and endometriosis out of a 65-year-old who came to see me from Washington, Central Washington. So we do see it, and the symptoms are the same symptoms they've been having their whole life.
Can teenagers have surgery?
Absolutely. Yeah.
Oh.
Early on in my career, I did a discoid bowel resection on a 14-year-old. Like literally took a 4 centimeter chunk of endometriosis out of her rectum. So you absolutely can have it's hard. I mean, that one was easy because it was a big chunk of endo on her rectum, on the anterior wall of her rectum. But the endometriosis otherwise in teenagers is tough because it's so hard to see. And our pathologists get really confused on it. So we'll do these surgeries on these 15, 16, 17-year-olds, and we'll send like 15, 20 specimens. And every single one of them comes back negative for endometriosis on the pathology report. And you're just like, oh no, because then the patient's questioning whether I know what I'm looking at. I do, I promise. But it's the pathologists get confused with those real immature lesions sometimes, and so they don't always know what they're looking at. Same goes for postmenopausal patients. A lot of those specimens come back negative on pathology for endometriosis, but it's endo. They get confused as to what they're looking at.
Possible to have lasting nerve damage with endo or adeno?
Yeah,
Lasting nerve.
yeah, of course, yeah.
How many surgeries has he done on somebody that has had a hysterectomy in the past that's had endometriosis ablated?
Did you catch that?
How many surgeries have I done on patients who've had a previous hysterectomy?
Yeah.
A lot. I don't know.
Yeah.
Probably at least 1,000, I would say. And that's unfortunately, most patients, that's how they come to find me because they had a hysterectomy and they still have pain and they're being told, well, it's not endometriosis because I did a hysterectomy on you. And yeah, I would probably, yeah, probably a fourth of my patients. So maybe 1,000 have already had a hysterectomy.
How often do you see insulin resistance or a diagnosis of leaky gut syndrome?
I don't know that I could put a specific number on it. Is there an association? Yeah, for sure. Maybe not. Well, do we see higher rates of insulin resistance? Are you talking like PCOS type stuff, or are you talking like pure insulin, like type 2 diabetes type
I've
stuff?
just been told there can be a connection. I have personally of insulin resistance, no idea why, and I've also been given the diagnosis of leaky gut syndrome just as like a diagnosis of omission.
Yeah.
How I
Well,
often see that, and it's turns out that it's tied to stuff you do.
I don't know that I can give you an exact percentage on that. I really don't know that I've tracked anything like that. So I don't know. We do know there's an association with leaky gut. Shanti Moling, who's in Portland, who works with Nick Fogelson. She and I trained at the same fellowship program. She was the fellow after me. But she's done a lot of research with leaky gut, and they actually she has shown in her research that there's something about endometriosis that actually does increase the gap junctions between the cells of the intestinal tract. So endometriosis is a known cause of this so-called leaky gut syndrome.
There's some more virtual questions I think that popped up.
Yeah. Would a general surgeon see endo on the appendix? No, they wouldn't probably. They're not.
No.
Most general surgeons aren't looking, they don't really do endometriosis. So we would see it better than they would for sure. And the appendix generally, if the question was the person had an appendectomy due to suspected appendicitis, but question if the symptoms were due to endo, I mean, it might have been. And if the pathologist wasn't necessarily looking for endometriosis, you have to do like a special stain to pick up endo. So they're not routinely doing that on appendix specimens for appendicitis. So they might miss endo. The pathologist might miss endo, but yeah, general surgeon, we would be far better at seeing it than a general surgeon. Um, I see a lot of endo patients who've also had their gallbladder out. I feel that endo could have been caught then and out at 6 years due up. We do see a lot of patients who've had their gallbladders out, and it's not necessarily because there's endo in or on the gallbladder, but I think things like pelvic floor dysfunction, diaphragmatic disease, if you have endometriosis up the sidewall and kind of radiating up, it can cause a lot of right upper quadrant pain. And that can often be mistaken for gallbladder pain. So we do see a ton of patients who get their gallbladders out for kind of this chronic right upper quadrant pain, and their gallbladder's totally normal, and they usually still have pain, or they do still have pain afterwards, so they get their gallbladders out. So does an 8 to 10 centimeter endometrioma always require or generally require surgical treatment? Yeah. Probably, I wouldn't sit on an 8 to 10 centimeter endometrioma. I wouldn't sit on that because it can torse, it can rupture. It's those endometriomas are awful for overall ovarian health. So the longer those endometriomas sit there, the more normal ovarian tissue gets destroyed, the more fertility drops. So yeah, I wouldn't sit on an 8 to 10 centimeter endometrioma. I think that needs to be um, and treated, and so surgically treated. Does adenomyosis always require hysterectomy? Well, again, it goes back to what are the indications for surgery? It's either pain or fertility. So if overall if you have known adenomyosis and your symptoms are relatively well controlled, no, you don't have to have a hysterectomy. It's always just patient preference and what the patient's going for. So, is it possible for polyps found during a colonoscopy to be endo? No, polyps are polyps. Yeah, polyps are polyps. No, they're different. If a patient has had a hysterectomy and still having pelvic pain post-operative at 8 week, would you treat that or would you recommend, or what would you recommend? I would recommend sticking with pelvic floor physical therapy. It says she's currently seeing a pelvic floor physical therapist, but I would recommend continuing just with pelvic floor physical therapy. I think hysterectomies are harder on the pelvic floor than a lot of providers realize. There was a big study done in Sweden. When was it done? Early 2000s, I want to say. But they had this registry of patients, like 10,000 patients who'd undergone hysterectomy, and they found that in patients who had underlying pelvic floor dysfunction prior to the hysterectomy, a lot of them got worse or had persistent had worsening or persistent pelvic floor dysfunction. And in fact, in patients, a small percentage of patients who had no underlying pelvic floor dysfunction prior to hysterectomy, the hysterectomy actually caused pelvic floor dysfunction. So I would just recommend for that in that particular case. Are you guys able
Now you can ask her.
Yeah.
to therapy if stopping
Oh.
pain? Yeah.
Oh, you froze. Ask your
Oh,
question.
Okay, so my question
oh,
is, if you
that's
see
weird.
that have had hysterectomies, in patients that have had hysterectomies and the fulguration, do you see a reduction in pain after an excision?
I couldn't quite hear the question. I'm sorry.
Hysterectomy, fulguration, and pain afterwards.
Do you find excision?
Do you find excision helps the pain? If they've had the hysterectomy, they had fulguration, but they're still having pain?
Oh,
Excision.
absolutely. Yeah, absolutely. Because the hysterectomy didn't treat the endometriosis and the fulguration didn't treat the endometriosis. So yeah, no, I absolutely still think there's a role for excision surgery following hysterectomy if patients are still having pain.
Uh, if I have endometriosis or a family member, what are the chances that my daughter will have it?
70%. There's a 70% maternal inheritance rate. There's a 20% paternal inheritance rate. So if um, you have a daughter, like if you don't have endometriosis, but you have a daughter and your husband or partner has a mom or sister with endo, there's a 20% chance that your daughter will have it. So there's a 20% paternal inheritance rate and a 70% maternal inheritance rate. Stuff is very genetic. It is very, very, very genetically driven.
Okay, is there ever a case where if someone has adenomyosis, is excision ever helpful for, just an excision surgery, not a hysterectomy, ever helpful for that?
No, unless there's endometriosis present.
Well, if you have both, if someone has both.
Yes.
Oh, yeah.
Sorry.
No, for sure.
Yeah.
If someone has endometriosis and adenomyosis, then yes, um, an excision surgery can be very beneficial, but you have to have that conversation with the patient that they're probably still going to have painful, clotty, heavy periods. So, and I have that conversation all the time with patients that, hey, we're going to go in and excise all this endo. And the idea behind it is, hey, maybe we're going to get your pain from 3 to 4 weeks out of every month down to like 3 to 5 days out of each month when you're actually on your cycle. Like that's the goal. But there will still be an element of pain on some level with adenomyosis. So yes, I think excision surgery, there is absolutely still a role for excision surgery for sure. So
Pathology report say that I have old endometriosis, is that a date?
Is old endometriosis on a pathology report a real thing?
old endometriosis on a pathology report.
Error reading perhaps?
Like the pathology report says this is old
It literally
endometriosis.
says old endometriosis on our pathology report.
I don't know that I've ever seen that before, actually.
Maybe you can speak to what it looks like postmenopausal and it's kind of burned out, like what it's.
Postmenopausal burnt out appearance.
Yeah. So I mean, it definitely changes appearance over time, and so in the young patients, it's clear white and much harder to see, and generally that's how it looks in postmenopausal patients as well. And so a lot of endometriosis over time, long periods of time. So these are the patients in their late 40s, 50s, or postmenopausal, or who've had it fulgurated. It oftentimes will destroy the glandular component of the endometriosis. So there's endometriosis glands and endometriosis stroma. The stroma is like the connective supportive tissue kind of between the glands of the endometriosis that are in that endometriosis lesion. So over time, you lose that glandular component, and or if it's been fulgurated, or if it's been progestinized, or it's been menopaused. I don't know if that's a verb, but I just made it one. If it's been menopaused, then yeah, it'll change appearance pretty significantly, and it is harder to see again for us and for the pathologist. But because we see so much of that, we know still what it looks like. But I've never seen a pathology report actually say old endometriosis. They'll sometimes like call it, I guess sometimes maybe that's another way of saying hormonally inactive endometriosis, because that's what I was starting to allude to earlier is that, yeah, over time it kind of becomes, it ceases to become hormonally active, and then you're just left with sort of this chronic. So a lot of pathology reports in perimenopausal patients or patients who've had their endometriosis previously fulgurated or progestinized, um, it'll come back as like chronic inflammatory tissue. Essentially, we do see a lot of that. It'll say fibrotic tissue with chronic inflammation is what those path reports come back as.
So is PCOS and endo connected, and how are they connected?
Can you talk about PCOS? Is there a connection? Do you see it? Can you see it when you're doing surgery? That was a kind of question that came up, but also what's the correlation? Can you have both?
Oh, you can absolutely have both. I don't know that there's a direct correlation between the two, but endo is one of those funky diseases where if you have endometriosis, there's a 85 to 90+% chance that you're going to have additional pain generators. You may completely disagree with me, Tara, but I don't necessarily think that PCOS is a major pain generator. But I don't
I agree.
know. Yeah. So. So yeah, I don't know that there's a direct causation or correlation between the two, but we do see it a lot. And you can see PCOS during surgery. You'll see all these the ovaries usually enlarged for one. So the ovaries and PCOS are huge. And then you'll see all these little follicles kind of ringing the ovary, which is what you see on ultrasound as well. So
And Dr. Iris Bulbrock just recently on an interview was saying that PCOS does not cause menstrual pain. So when these women are
Yeah.
told
Correct.
they have menstrual pain, oh, you have PCOS, she's like, PCOS does not cause menstrual pain, is what Dr. Bulbrock had said. So she's like, that's most.
who said that, sorry?
Iris Bulbrock.
Yeah, no, I agree with that. Yeah, I don't think PCOS causes menstrual pain.
There's some more chat questions I think that came up. Anybody else here have any before we? Oh, yeah.
Can you talk about the impacts that, excision surgery can have on fertility outcomes and like what you see with your patients?
Fertility outcomes for doing excision.
Oh, I think they're night and day. I mean, I think that I think excision surgery drastically improves chances of natural fertility. And that's been shown in the literature. That's not me just spitballing. That has been demonstrated in the literature that excision surgery is vastly superior when it comes to improving fertility. And the data is kind of, the papers are all over the place, but it is absolutely been shown to be beneficial. So there was a question if not all the endo, or if that all the endo was not removed to protect the ovaries for fertility concerns, would you consider prescribing progesterone? Sure. Yeah, I think it's all in an individualized case by case basis. Sure, I would do that. What's the strangest place you found endo? Well, in a man. We there was a case in fellowship of a small bowel obstruction, and the general surgeons and it was a man. It was a male patient with a small bowel obstruction due to endometriosis. So, but where there's actually 14 cases of endometriosis in men, being pathologically confirmed endo in men. So not just the disease of menstruation. Where's the strangest place that I've found it? I don't know, actually. I mean, we see it. I've taken off diaphragm all the time. That's not really strange, though. I've taken in the last week, I've had two patients that I've taken really big, rock hard endometriosis nodules out of their C-section scars, like up in their skin. So a patient that I operated on 2 Mondays ago had she had 3 C-sections, and then last fall she was having a lot of pain in the corner of her C-section scar on her belly, like on the outside, and kept getting told, oh, it's fine, it's fine, it's fine. But she could feel like a hard mass there. And then last fall it actually erupted, like her C-section scar split open. And so she got sent to general surgery, and they did an IND on it, an incision and drainage, basically sort of like kind of cut away in the office as much as they could. And when they sent it to path, it came back as endometriosis. So we took her to the OR on last Monday and actually removed a pretty good size, probably like a 4 centimeter nodule of endometriosis that had been growing in her C-section scar. And then we had another one just this Thursday, same thing, big old nodule of endometriosis in the C-section scar. So yeah. Yeah.
Youngest patient you did a surgery on to end it.
The youngest patient I've operated on, 13. And we don't generally recommend that right off the bat. I'll be the first one to say that I'm not real excited about taking a 12 or 13-year-old to the OR, but I've done it. Yeah, 12 actually, I guess would be the youngest. And we found endo. There was pathologically confirmed endo. But those patients, yeah, generally we'll try some kind of like hormonal suppression first, just because teenage endometriosis is tough. There's higher recurrence rates of it, and you talk to any endo expert, and most of them will agree with that sentiment. That so I don't think there's anything inherently wrong with trying some kind of hormonal suppression first. In these really young patients, but not every 12, 13-year-old needs surgery, but these were patients in pretty debilitating pain despite having tried hormonal suppression. So yeah, 12, 13 probably is the youngest.
Well, we thank you so much for doing this
Yeah.
today and taking time out of your Saturday and all that you do for the endo community, of course, and your patients. So thank you, everyone.
You're welcome. Thank you, guys. So, all right. Have a good one. Bye.